Thank you, and nice to meet you all attendees. I don't say good evening because all of you doesn't have evening now, since we have it in Europe. I'll first declare my conflicts of interest. I have no current conflicts of interest to disclose, but since I've done this type of surgery with lumbar disc prosthesis in mid-90s, I've been in close contact with most of the manufacturers of disc implants, but does that doesn't give any conflicts of interest. Just widen my experience. When we pick out patients for lumbar disc arthroplasty surgery, this is something that gives superficial results compared to fusions. There are so many published articles on that, so I've not cited them. We know that, but we have to select the patients right. Not only does it give better function, less pain, and so on at both short and long term follow up, but it also give a marked reduction of the risk of ASD, adjacent level disease, in the future. But it's demanding for the patients. They really have to take part in this, and I'll come back to that. So let's start with the patients that are suitable for TDR. We are planning to treat long-standing low back pain that is believed to be caused by lumbar disc degeneration. Compared to the cervical, we accept patients without sciatica or radiating pain. We can treat people that only have low back pain, but several of them also have radiating pain. The patients must have tried physical therapies before we do the surgery. First of all, to know that that is not enough for them, and also to see their interest in taking active part in what's coming. If the patient have a concomitant disc herniation at the segment, it's not the reason we treat the patient, but it's causing problems. Even if low back pain is the main problem, that doesn't present a problem. We deal with both problems at the surgery. We have to think, is this a localized degenerative disc disease in one or a few segments? And if the answer is yes, the patient is candidate for this. We have to see in what shape the facet joints are. If they are severely arthrotic, they shouldn't be treated with a mechanical disc. If they are just slightly arthrotic, we could consider a viscoelastic disc. We have to consider if anterior surgery through the abdomen is possible, and then it's a go. And the question that I come back to is the patient prepared to take responsibility for his her share of the treatment process? I actually tell my patients that they are going to be my slave for a year. And if they accept that, they're going to do what I tell them. And that is important. That is part of the patient selection. This is examples of two patients that have developed hyperlordosis with facet joint arthritis after total disc replacement. If they were treated preoperatively with extensive stretching and prolonging of lumbar muscles and strengthening of abdominal muscles, they should have had a good chance to avoid this problem with the facet joints that doesn't come until a couple of years down the line. So therefore, it's so very important to have the patients working together with you. If the patients have had previous surgery and it's contemporary lumbar herniation surgery, it's not a problem if the facets or laminae are not removed. If they have been through bone decompression, it's probably questionable, since the facet joints must have been in bad shape as the reason for the need of decompression. So that would probably not be a suitable case. Previous fusion, yes, when they get their adjacent segment disease, they can very well be candidates for TDR in neighboring segments. So what patients shall we avoid? First, I come back to that. This is third time. Patients that are not willing to do physical therapy prior to reaching you will most likely not do their share of the pre and postoperative activities and restrictions. If the majority of symptoms are due to nerve compression by herniation, it might be a better idea to solve that. Just remove the herniation in microsurgery or something else, and see if that removes also most of the problems. Maybe the patient doesn't have a severe low back pain after all. It's the sciatica that is a big problem. We have to deal and think about this. If we cannot localize the painful segments, we have a problem. I use, when I'm in doubt, provocative discographies of degenerated disc. We all know that discography in itself can induce degeneration, but if we use it on already degenerated discs, that is not an ethical problem, because we need to know exactly if they have five degenerated segments in the lumbar. We have to know which of these segments are the ones producing the pain. We don't operate on the MRI scan. And if there is a facet joint arthritis, for mechanical implants, my experience is that they should be virgin, otherwise they will develop a issue with them. With viscoelastic implants, they are more forgiving since there's a counterforce against hyperlordosis that helps protecting the facet joints. If there is a spondylolysis, we shall not use total disc replacement. I haven't tried it with a viscoelastic because for me it's a contraindication, but I think it's adventurous to do it. Then we have patients that are not suitable for anterior surgery. They might have a serious scarring after major abdominal surgery, not only an appendix or a gynecological surgery or something like that, but major abdominal surgery. Then it might be something we won't get in again in. They might have ongoing vascular conditions or weakening, like Ehlers-Danlos syndrome, which one sort of have very, very weak vascular structures. In Sweden, we don't do this type of surgery if BMI is over 28. That is lower than in other countries, but we feel it increases the risks a lot. It's very complicated to hold everything to the side when the abdomen goes very, very deep. And I have so many motivated patients that have heard that, and then they come back a year later and are in the right side of this border. If they're not motivated to reduce weight, they won't be motivated to do what you ask them to otherwise. On the other hand, the ones that have reduced from 34 to 28, they are my best patients because they obey me even after surgery, and they are so motivated. Then we might have patients with weakened bony structures of end plate, former fracture, or osteopenia. That is also a contraindication. This is a patient that had a prior vascular surgery, but as you can see, it was on height L4, L5, and the patient needed a disc in L5S1, and then there was not a contraindication. But if the disc problems would have been one segment higher, it might be really hard to get there. So a number of patients have contraindication. Are there any left? Yes, a lot of patients are left. But we must remember, as we were told from the cervical, to use a hybrid technique when one or two segments are not suitable for TDR while other segments are. With this thinking and this in mind, there are only a few patients that cannot benefit from preserved maintained mobility at some segments. And the more mobility we can preserve and restore, the better for the long-time results for the patient. So we're really going to try to have as many segments as possible staying mobile. And that's why I do a lot of hybrids too. This is an example of a hybrid with a spondylolisthesis of L5S1, also two degenerated discs on top. And everything is solved from front, and at least the patients have maintained mobility at 2 out of 3 segments. If mobility is earlier sacrificed and led to adjacent segment disease, you can at least restore mobility at the next segment, as shown in this picture. The fusion was like 5-6 years earlier to the TDR surgery. And this is 2 different patients that have the same type of implants in the same segments. But if you look at the left one, you can see that process is shifting over to hyperlordosis. And that would put her facet joints in risk. So when I saw this, I started an extensive program. The other patient with a very straight spine does not at all have this risk. Thank you very much for letting me present.